Welcome to the Neuromodulation Podcast, presented to you by the International Neuromodulation Society. Dive into the forefront of today's emerging neuromodulation techniques, insights, and ethical and clinical applications. Subscribe now to join the multidisciplinary collaboration of medical care providers, scientists, and engineers who are part of the global conversation that's shaping the future of healthcare.
Welcome to today's episode of the Neuromodulation Podcast. I'm your host, Mandi Soleil, and in part one of this three-part series, we're going to dive into the world of neuromodulation with Dr. Christopher Honey, a leading expert in the field. This episode explores the impact of neuromodulation, specifically deep brain stimulation, focusing on a patient case study with respect to Parkinson's disease. Dr. Honey will share insights into the neuromodulation landscape, common themes in patient outcomes, and how he stays at the forefront of technological advancements. Welcome to the show, Dr. Honey.
Thanks for having me, Mandi.
So I'd love to help our listeners understand just the broad overview of why you've chosen the field of neuromodulation. What excites you about this space?
My whole world is neurosurgery. And inside neurosurgery, there are different specialties where you might operate on children or remove tumors or deal with trauma. But one of the most gratifying areas for me has been neuromodulation, because you can improve someone's life so much and give them back the quality of life that they were missing.
And how long have you been working in neuromodulation?
Since the late 1990s. Yeah, a long time.
Can you tell me a little bit about what the evolution of the field has looked like in your practice?
Back in the early 2000s or late 1990s, we were trying to modulate the brain by making lesions. That was in the era of the pallidotomy, thalamotomy, and those are very good operations designed to destroy certain parts of the brain that are functioning poorly. The weakness of it is that it's a one-shot deal. And if the patient progresses 10 years later, you don't have the ability to chase down the disease anymore because you have already done your operation a decade earlier. And what I like about neuromodulation is the ability to fine-tune or adjust the effect to match the individual patient's needs. So if you make someone really good today, they might not be good in 5 years, but you could adjust the stimulation, like adding a medication, and maybe turn up the stimulation so that you can recapture the quality of life 5 years from now. And conversely, if you turn up the stimulator too much and they get a side effect, like some tingling in their fingers or a slurring of their speech, you can turn it down and they can tell you, oh, okay, that side effect has gone away. I like the individualization of this therapy for every single patient.
And can you give me an understanding of the breadth of therapies that you work with in your practice?
Yeah, the bulk of my work is Parkinson's disease, but we also do tremor, dystonia, and I do a lot of pain surgery as well. The bulk of our work is Parkinson's disease.
And how does neuromodulation address Parkinson's disease?
Not every patient with Parkinson's needs neuromodulation, particularly early on in their Parkinsonian career. For the first 5 years, medications are probably excellent. Then between 5 and 10 years, sometimes you get side effects from the medications, and the neurologists have a tough time working around it. And that's when deep brain stimulation can step up. Deep brain stimulation for Parkinson's is particularly good for 3 types of motor complications that tend to occur later in the disease. And they are on-off fluctuations, or otherwise known as wearing off, dyskinesia, and tremor. And if the neurologist can't control those symptoms with medications, the neurosurgeon can often step in and be very helpful with those particular problems.
Okay, can you explain what dyskinesia is?
Yeah, I'm actually, with your grace, I'd like to explain each of those motor complications.
Please.
Yeah, so the most common motor complication is called on-off fluctuation or wearing off. And this is when the medications don't last long enough. At the beginning of your Parkinson's, you're probably taking 1 tablet 3 times a day, and if you didn't take that tablet, you'd be slow and stiff and shuffling and stooped. But when you take the tablet, the dopa gets dissolved from your stomach into your blood and up to your brain, and the dopamine levels are normalized. So you're moving quite well throughout the day. Now, the pill wears off, but before it wears off, you take another one. And maybe you're only taking 3 pills a day, and your life's pretty good. But eventually, you need to take more and more medication more and more frequently. And there comes a point when you're taking a lot of pills every 3 hours. And the pills kick in and work beautifully well, and then they wear off before the 3-hour time mark. And so you're moving really well. We call that on. And then your pills wear off, and we call that off. And you're slow and stiff and shuffling and poor balance. And it's happening every 3 hours. And so if that's happening, it's hard to plan your life. I want to go out to do some shopping, but oh my gosh, my pills are going to run out in 3 hours. I can't plan that. And so the quality of life begins to suffer. And that's called on-off fluctuations, where the medications are working and then they're not. And so what are you going to do? Shorten your pills to every 2 hours around the clock or every 1 hour? And that particular problem can be solved with deep brain stimulation of the subthalamic nucleus. And we have a lot of examples of that.
I actually want to back up for one moment and say, what is Parkinson's? Where does it come from?
Yeah. So Parkinson's is one of the neurodegenerative diseases, and you're losing a specific brain cell, a brain cell that makes dopamine. And the ramifications are protein, but the most obvious ones are seen in the motor movements. You get slow, stiff, tight muscles. You can get a tremor. Your posture bends over, you get short shuffling steps, your balance goes, and it's all because you're missing this chemical in your brain called dopamine. You can replace that chemical by taking a pill that has dopamine in it. But as your Parkinson's progresses, it's hard for your brain to absorb that pill and let it out slowly to last. And so you're getting the benefit of the dopamine, and then it's running out before you're taking your next pill 3 hours later. And in order to smooth that out, you can get deep brain stimulation of a specific nucleus in the brain, the subthalamic nucleus, or STN for short. And what that does is the effect of the stimulation is very much like the effect of dopamine. And the beauty is it's on 24/7. So whatever the pill can do, the stimulator can do. So if you're really good with the pill for an hour, you can be really good with the stimulator for an hour, except the stimulator doesn't wear off. And so you can stay at that good level round the clock. So with the STN-DBS, we can't make you better than how you were at your best last week, but we can capture that moment when you were at your best and stretch it out all day, and the patients love it. So that's the first motor complication that deep brain stimulation or neuromodulation can treat. The second motor complication is called dyskinesia, and you were asking about that earlier. And dyskinesia looks the exact opposite of Parkinson's. It's a excessive movement where you're dancing, wiggling, can't sit still. And you've probably seen Michael J. Fox sometimes looking like he's dancing or wiggling or can't stop moving. Mm-hmm. That's dyskinesia. And that's often too much medication. And the neurologist can pull back your pills and get rid of the dyskinesia. But what happens is it shifts the curve down, and you spend all your time stiff and frozen and slow and with not enough medication. And sometimes the patients are caught between a rock and a hard place, where they have this fine balance between too much medications and they're wiggling and falling off chairs, and too little medications where they're frozen and can't get up off of the chair. And the second operation that we do is deep brain stimulation of a slightly different nucleus, the globus pallidus internus, short form GPI, and it's very good for dyskinesia. And if you have a patient who's got dyskinesia who gets DBS of the globus pallidus or GPI, we can pretty well block at least 80% of the dyskinesia. And so what happens is they continue on their medication, but they don't have to worry about the side effects of dyskinesia. And sometimes with the dyskinesia blocked, the neurologist can even push their medications harder if they need to get out of that slowness, stiffness. And that way it's a partnership between the neurologist who's pushing the medications, trying to push dopa into the brain, and the neurosurgeon using DBS to block the side effects of those medications. And that basically smooths the patient out. And the third motor complication that can be sometimes very difficult to treat with pills alone is tremor. Tremor is a rhythmical shaking that interferes with your ability to feed, clean, or dress yourself. And the majority of patients with Parkinson's have tremor. And the majority of those patients, their tremor responds nicely to the medications. And so all they have to do is take their medications to get rid of the tremor. But there's a subset of Parkinson's disease where the tremor does not respond well to the medications. And those patients can have deep brain stimulation of another nucleus in the brain, the thalamus or ventral intermediate nucleus, VIM. And VIM nucleus, DBS, is very good at blocking tremor. So those patients continue to take your medications to help them move. And usually moving is not a problem for them. The problem that's really interfering with their quality of life is their tremor. And then the thalamic stimulation can block the tremor and improve their quality of life. And those are the three motor complications that you tend to get a little later in your Parkinson's that can be very difficult for the neurologist to treat with medications: on-off fluctuations, dyskinesia, and tremor. And all three of them are beautifully treated with deep brain stimulation.
And I certainly want to dive into deep brain stimulation, but since we've gone through the motor implications of Parkinson's disease, I'm aware that dopamine can also have an effect on the mental health of somebody. So
yes.
Can you help me understand the mental health implications of having Parkinson's disease?
Yeah. So a while ago, we thought that the Parkinson's was just a motor problem. They were slow and stiff and shuffling and bent over and poor balance, but clearly it's multi-system. And the worst case scenario is there is advanced Parkinson's patients can get dementia and cognitive impairments. And we don't have a treatment for that. Certainly neurosurgically, we don't have a treatment for that. There are mood issues associated with Parkinson's disease. They can get depression, and those have to be treated by a team of medical specialists and is typically not treated by the neurosurgeons with deep brain stimulation.
Would you say that all of these symptoms are coming from the dopamine system?
Yeah, it's clear that there's more cells affected than just the dopamine, but that is the big one that's affected. But the ramifications are huge because they can have autonomic problems, they can have constipation, problems urinating, they can have pain. It's clearly more widespread than just slow, stiff, and shuffling.
Okay. So now digging into deep brain stimulation, help me understand what that is.
Deep brain stimulation is a method of applying an electrical current in the brain. And so there's really three parts to it. The first part is putting a platinum wire into the brain, and it's placed deep into the brain and the basal ganglia.
Hence the name.
Hence the name. And that is often done, has to be done through a small hole drilled in the skull. And then the electrode is a platinum wire that's insulated except at the tip where the platinum is. And that is placed very accurately into the part of the brain that you want to stimulate. STN, GPI, VIM, all these different nuclei in the brain. Mm-hmm. That electrode is then connected by a wire underneath the skin down to a pacemaker or an implantable neural stimulator that typically sits in the chest. The implantable neural stimulator is like a pacemaker for your heart. This is an implantable neural stimulator for the brain, and it's basically got a computer, a battery, the ability to be adjusted through your shirt with a mouse kind of thing. And then that current travels up the wire. The wire is typically steel because you bend your neck 1,000 times, and that's exactly how you would break a wire, by bending it back and forth. And the steel wire it's very thin underneath, you can't really see it. And then it goes up and it connects to the platinum wire, which then delivers the electricity to the part of the brain that you want to stimulate. Then afterwards, you can go to the clinic where through your shirt with a computer, you can turn up the stimulator, turn down the stimulator. And nowadays with the newer technology, we can lean the stimulation effects to the left or to the right or forward or backward to get into the area that you really want or get away from an area that's causing you side effects.
Okay, and what might some of those side effects be?
It all depends on the anatomy. And if you are near part of the brain called the internal capsule, you will get either a tightness or a tingling on the opposite side of your body. And if it's a tightness near your throat, it'll throw your voice off a little bit. But as soon as it's not a lesion, it's a modulation. So if they say, oh, I don't like the way it's affecting my voice, you can turn down the stimulator. And if you know the anatomy, you can guide the stimulation away from the source of that side effect.
So can you tell me about the actual implantation process? And I want to specifically also hear about your thoughts on the debate that exists around whether or not the patient should be awake or not.
Yeah, so I'm biased because I'm in the awake camp.
Okay.
But I have done DBS asleep. But I'll tell you how I do it. I do it awake, and the patient is surrounded by a team, and they get a sense that the team has done this a lot and are competent. We have video that the patient is watching during the surgery, and it's a live feed of one of my favorite beaches in Hawaii. And they watch the sun come up, and they watch people, and they imagine one day that they're going to be there. We have music. Sometimes the patients bring their own playlist. One patient, I remember, specifically brought Staying Alive as the opening. It was a little joke to the team. So we have music, and we have a dedicated nurse who's looking after the patient, holding their hand, making sure, and if they need anything, they're right there. The operation itself, the only uncomfortable part is putting the freezing in, the local anesthetic. And then after that, there's no discomfort.
Can you speak to what level of discomfort are we talking that folks should be prepared for?
If you've ever had stitches and they put the local anesthetic in, it's like a bee sting.
Okay.
And then if you put the local anesthetic in really slowly, it doesn't hurt nearly as much. If you put it in really fast, it really is a sting. But putting freezing in the initial needle is uncomfortable. There's no question about it. As to the debate of awake or asleep, there's pros and cons for both. I'll give you the argument for awake because that's what I do. If you're going to have your brain surgery, I would like to ensure that the electrode is not just in the STN nucleus, but it's in the absolute best place inside that nucleus for you. In order to target the nucleus in the brain, we can see it on the MRI. And the MRI can get us within 2 millimeters of exactly where that target is. We want to be a little bit better than that. And so we put a microelectrode through the brain and listen to the electrical activity of the brain. And different parts of the brain have different languages. And we recognize the language of the STN nucleus. So when our electrodes are in it, we recognize that we're there. I like to put 2 or 3 electrodes into the STN nucleus, and then I can test which of those 3 is the absolute best for the patient. And I think when the patient is awake, I can test the electrodes. And what we do is the patient is off their medications, so they're very Parkinsonian, stiff and rigid. When we turn on the stimulator in the STN, their Parkinson's will melt away, and it will melt away at a certain voltage. And you have to turn up the voltage and then see where is the threshold for a clinical benefit. And let's say it's at 2 milliamperes. Then you keep turning the stimulator up until you get a side effect. And, oh, my throat, my voice is off, or I'm getting tingling in my face. That's the side effect threshold. And if there's a big gap between the clinical benefit threshold and turning up to the side effect threshold, that's a very good electrode because we'll be able to use it for years and years. Because when we have to turn up the stimulator 10 years from now, we'll know it's still not going to cause a side effect. And if the electrode number 2, it happens to be 2 millimeters away, and it has a clinical benefit, and the clinical side effect threshold is a little bit lower, I don't want to use that one because I know it'll work this year, next year, 3 years from now, but maybe not 5 years from now when I really have to turn it up. And so when the patient is awake, I can get that data. What's the threshold for making you better? And what's the threshold in your body for giving you a side effect? And that way I know of the 3 electrodes in your SDN, I know which one is the absolute best one for you. And I don't think you can do that when the patient's asleep. I think you can hit SDN for sure. But can you say that's the best place, or can you just say I'm in the SDN? If you're in the SDN, the results will be great next year and 2 years and maybe 3, but 5, 10? So I'm still biased by I have one opportunity to place an electrode in that patient's brain. I want that electrode not just good or adequate. I want it as perfect as I possibly can. And I think in order to do that, you have to be awake because you got to tell me what's the side effect and what's the clinical benefit. The upsell of doing it asleep is they're doing it faster. So the hospital is saving money, and preoperatively, the patient's thinking, yeah, I'd rather have this done asleep. Yeah, I can see that argument. And occasionally we have had patients who say, I just don't think I have the fortitude to go through can you do it asleep? Answer, yeah, absolutely. Do you accept the fact that I might not get the optimal electrode location, but I'm going to get a very good one? Yeah, for sure, because I don't think I can go through it awake. I've had a lot of patients fall asleep during their operation.
Wow.
Because they typically get a lousy night sleep the night before. And then when they're in the OR and they're watching Hawaii and the music's going and they just fall asleep because they get a sense that the team's done this before. For us, it's just another Tuesday or a Wednesday. And for the patient, I appreciate that it's huge.
Thanks for that. And when we talk about the clinical benefit and evaluating that, my understanding is that patients have to come off their medications.
Yes.
And so what you're assessing is in the moment, you turn this device on and then you're able to observe immediately, does the tremor dissipate? Is that accurate?
Yeah, that if you take your medication, sometimes you'll get dyskinesia. We can't have someone wiggling when we're trying to put an electrode through their brain. They have to be still. So that's one, they got to be off their meds. 2, when you're off your meds, you're really stiff and tight. They know what they call it off. I'm off my meds. And when you are off your meds and you turn the stimulator on, and if it's in the right place, their tightness and rigidity will melt away in front of your eyes. And so you'll know you've got the clinical benefit. And as you're slowly turning up the stimulator, you can see what is the threshold to cause this clinical benefit. And you want that threshold super low. And then you keep turning up the stimulator until they say, oh, I'm getting a side effect. I'm getting tingling in my hand, or my eyes are wiggly, or my throat, I can't talk as clearly as I could before. Oh, okay, that's the threshold for your side effect. And then we know what the clinical threshold and side effect threshold is. And if it's a huge gap, we know that's a great electrode location.
Maybe an odd question, but is there ever a time when a patient has never tried medication and deep brain stimulation is step 1?
No.
Okay.
No, we want patients to have the optimal, safest therapy, and that's clearly medications early on. There were some studies to suggest deep brain stimulation works so well. People started saying, why not do what you said? Let's start with deep brain stimulation. And so what they did a little while ago was an early stim trial. After 4 years of Parkinson's disease, let's go to DBS and see how they do. And it was a trial organized out of Germany by a neurologist, Professor Deutschel, did a very scientific study where he had a group and he split the group into 2. One group got surgery. The other group did not get surgery, but had the best sort of medications, possibly. And the surgery started 4 years after the onset of Parkinson's disease. And what happened 2 years later was that the people who got surgery, their quality of life stayed stable. And the people who didn't get surgery but got the best possible medications, their quality of life dropped, as you would expect someone with progressive Parkinsonian symptoms. And so that was a stimulus to really look at doing DBS maybe as early as 4 years after. Then some surgeons said, if it works at 4, let's go earlier. Let's go hyper earlier. And there was no difference between surgery and medications if you go very early, except you're taking a risk if you're having brain surgery. And brain surgery has the risk of complications. And nobody thought it would be, if you're not getting any benefit, if it's no better than medications, then you're only taking a risk to have surgery. Nobody does surgery ultra early, like you were suggesting before the medications. The normal progression would be start on medications, see how things are going. Maybe you never need DBS. But if you do develop one of those 3 motor complications, on-off fluctuations, dyskinesia, tremor, okay, let's now look at the balance between improving those symptoms versus the possibility of a complication. And so if the benefit outweigh the risks, yeah, let's have surgery. And if the benefits don't outweigh the risks, then let's not have surgery.
I'm aware that you've done over 1,000 procedures.
Yeah.
In that, what have been the most common complications you've seen that have come up?
The most common complication is infection. If you put a foreign object, this pacemaker, underneath the thin skin of an elderly patient who has an immune compromised, they've got a chronic illness, you invite the potential of infection. Infections are around 2 to 3%. If they happen, it's a complication, but most of the infections go away with just a course of antibiotics. Occasionally, if the infection is deep into the device, has to come out, heal the infection, and then come back and replace it.
Okay. How often would you say that needs to happen?
Like 2 to 3%. It's actually quite rare up front when you get your operation. But when we implant the pacemaker, the implantable neural stimulator, it looks like a pacemaker. It goes underneath the skin in your chest or sometimes in your abdomen if you're particularly skinny. That will run out of juice, run out of batteries eventually, and will need to be replaced. And that replacement surgery, we do it as day surgery. You come in, you get the replacement, you go home a couple hours later. It has to be done in hospital where we can a sterile environment and scrub you and give you antibiotics. That has a higher infection rate. That's the 2% kind of thing.
Got it. Okay.
Yeah. The primary infection, like when you get your operation up front, that's less than that, around 1%. But the replacement surgery is in the 2 to 3% range. Yeah.
Okay. And I want to shift gears here and explore some other elements of your career and the work that you do.
Oh,
but
sure.
Before we do that, is there anything regarding deep brain stimulation for Parkinson's that we missed that you want listeners to hear?
Everything I've said is in black and white on our website, written for patients at drhoney.org, drhoney.org. And you can read it at your leisure and go back and your family can read it. Yeah, there's tons of things I'd like to say about it. I will say that Parkinson's disease, I appreciate that it affects an individual, but it really affects the family. And the decisions to have surgery, really, you shouldn't include the family because often the spouse comes in to be the caregiver. And the benefit and the potential risks affect them as well. And so it's important to make a decision as a family.
Tell me more about the impact on the family.
So the Parkinson's patient often has to stop work, but then often the spouse does too, to become the caregiver.
Oh.
Yeah. And then if patients are focusing and planning their lives around a 3-hour cycle of their medication, that impacts your ability to go shopping, certainly to do recreational activities, to travel becomes harder. I think it becomes the focus of their life. And what I like about the deep brain stimulation and giving patients back that quality of their life is that Parkinson's is always chipping away at you, always taking a little bit more each year, never giving back. Whereas all of a sudden, deep brain stimulation can give you back some quality of life. It's an analogy to when you first go on your dopaminergic medication, you feel fantastic and almost normal again. Like I don't have Parkinson's anymore. It comes back. And then that starts to wear off for 4 or 5 years. And then the DBS is an opportunity to get something back in terms of the quality of life. And that's nice for the patient and their family.
What does the postoperative window generally look like for patients of deep brain stimulation?
So our patients go home the next day. They have their surgery. They stay overnight, and then they go home the next day. The stimulator is in place, but it's turned off, and we leave it off for a couple weeks, typically 4 weeks. And then the patient will come back to the DBS clinic where the DBS clinician will slowly titrate the benefit of the stimulator. So turn up the stimulator, back off their meds. Come back next week. Turn up the stimulator, back off their meds. And the goal will be to be running on the stimulator and much less on the medication so that there's less of this hourly fluctuation and more rock solid benefit from the stimulator. And that takes a while because everyone's symptoms are different and you don't know exactly how much stimulation they need. And it's a fiddling and an adjusting, and we would say a titration of the therapy to the individual patient.
Do any patients move off of medications entirely?
Yes.
How often is that the case?
The truth is, in the old days, it used to be a sign that the surgeon had done a good job. And they used to say at meetings, 40% of my patients are off all their medications. And that turned out to be a bad thing because coming down too quickly or coming off the dopa can leave you sad. And our goal is no longer to get, initially we thought, let's get them off the meds and then there'll be no fluctuations whatsoever. And that was wrong. What we want, our goal is to make the patient quality of life as good as possible. And that often means leaving some medications, particularly for mood and some of the autonomic functions. And so it's used to be 40% of our patients were off all their meds, and now it's probably rare because we generally don't like it, but there's still some patients who just say, you know what, I just don't need the meds anymore. Yeah.
Can you discuss any data on the long-term efficacy of DBS in managing Parkinson's?
Yeah, so the stimulator will continue to do its job. But God forbid, if Parkinson's has degenerated all the brain cells in that area, there's nothing left to stimulate. And the stimulator will continue to work if your brain continues to be receptive to it. And the way you can tell if your brain is receptive to it is that you're still responding to your dopa medication. So if you take your Sinemet or your dopaminergic medication and you get better, it's very likely the stimulator will continue to do its job. But there does come a time, perhaps when there's very few cells left to absorb the dopa or very few cells left to be stimulated, where your dopaminergic medications don't work at all. That's very advanced end-stage Parkinson's disease, where you take a Sinemet and nothing happens. If that is where your brain is, then the stimulator's not going to work either. Yeah.
Okay. Interesting. So I'm wondering, are there any specific biomarkers or imaging findings that can help you predict whether or not DBS is going to be successful for a patient?
Yeah, there's a lot of research in that area. The one thing that is suggested that you're going to do well with DBS is your response to dopa. So there's the Unified Parkinson's Disease Rating Scale, the third subcategory of that. And it's a quantitative measure of how Parkinsonian you are. And what we do is we take you off your meds overnight and you come in and we measure you. And your score's quite high because you're very Parkinsonian. And then we give you your dopaminergic pills. You take your Sinemet and you feel the medications kick in and you're much less Parkinsonian. You're moving really well and your score drops down dramatically. And if there's a big difference in those two scores, that suggests to us you're going to be a great candidate for DBS. That has to be tempered by really understanding the entire patient. and what are their expectations. There can be a mismatch between what the surgeon sees and what the patient wants. And that's a recipe for disaster. So if I look at a patient and they have a tremor and they're a surgeon and they want to go back to operating, and I think, yeah, I can get rid of that tremor. You should be able to go back to operating. And I'm just focused on that. And I operate on them and their tremor goes away. But I didn't realize they have depression, they have pain, they have constipation, they have bladder, they have a whole bunch of other issues that are blocking them from going back to work. They don't have the motivation to go back to work. They're sad. I am not going to meet their expectations because I was too focused on one little symptom instead of understanding the entire patient and where they are in their world. And so, although we have all these tests that we try and do to try and guess, are you going to be a good candidate? It's very important to really listen to the patient and understand who they are, what they want. Can we give them back what they want? Yeah.
I'm aware that there are psychological evaluations that are required before a patient undergoes deep brain stimulation. How effective do you find those are?
If you were to operate on someone with profound depression and really improve their Parkinson's, but they still had a profound depression, their quality of life would not go up because they feel lousy. If you were to operate on someone who was profoundly demented but had bad tremor, and I got the tremor to 0, but they were still profoundly demented, their quality of life would not get better. Quality of life is a complex equation, but it is heavily weighted by cognition. If you are with it and understand what's going on, you can function much better fighting the good fight, adapting to your weaknesses and your symptoms compared to someone who is cognitively impaired and really can't. And psychological tests are important. It gives you a better picture of the whole patient. For the worst case scenario would be to take someone who is cognitively impaired and allow them to then move freely and leave the house and not know where they are. And the family said, we used to be able to leave grandpa on the couch watching TV and he was safe. And now you've made it very dangerous for him because he's walking out the door naked and going down the street. And it's important to have these psychological tests so you get a complete picture of the patient before you make a decision about whether improving one symptom, tremor, dyskinesia, motor, will actually translate into an improvement in their quality of life.
Well, how do you manage these patient expectations and maybe even stretch that to the broader care team? Because you don't necessarily get a whole ton of time individually with a patient.
Yeah, and we're a bit of a victim of our success because certainly in British Columbia, everybody knows somebody who's had deep brain stimulation and the stories are typically miraculous. And so we do have patients still coming saying, I want you to cure my Parkinson's. We tell them what we can and cannot do. One of the things that I found patients really understand is when I say, I'm not going to make you better than you were last week, but do you remember how you were when you were at your best last week? That's how good I can get you, and I'll try and keep you there longer during the day. Does that make sense? And then does that translate into, and they usually stop and say, that would be fantastic. The patients who say, I want to be better than I was. I'm falling now. I didn't fall 5 years ago. Now I'm falling. I go, if you're falling on your meds, you're going to be falling after your DBS. So it's important to temper expectations. Yeah.
So I want to get a little bit more technical here. Can you explain the technical differences in the approach taken between the subthalamic nucleus and globus pallidus interna stimulation options?
Yeah, we're a big fan of the STN nucleus. That is very good for patients who have on-off fluctuations. Patients who are really good on, but it's wearing off, let's say, within 3 hours.
Okay.
And we can keep them on and stretch that out. And that would be a good patient for STN DBS. contraindication would be someone who, and you said you wanted to get technical.
Let's go.
There's a condition called hypodopaminergic anhedonia, and that is when your dopamine is low, you get profound anxiety and sadness. Everyone, when their medication gets low in between doses, gets upset because they're not moving as well, but it's more of frustration and, oh, why is this happening? But patients with hypodopaminergic anhedonia, they get a real profound anxiety, black thoughts, darkness, sadness. It's uncomfortable. Those patients would be bad for STN because as we turn up the stimulator and make them move beautifully, we have to get rid of their medications. And they can move like Baryshnikov or Nureyev, but they feel horrible because their dopamine is low. They're curled up on the couch, and if you tell them, go do a pirouette, they can, but they say, I don't feel like doing that. I don't like this. And so that would be a great patient for GPI DBS because you keep the medications up, their mood won't change, and you can get rid of their symptoms with the DBS. So essentially, GPI DBS might be good for someone that has a fine balance between dyskinesia and moving well. If, for example, a patient takes their medications and they're slow and stiff, we call it off, and they go straight into on with dyskinesia. So they're moving, but they're wiggling with the dyskinesia. And then they go from on with dyskinesia to off. And it's a knife edge. There's no on without dyskinesia. They just click on with dyskinesia. That would be a bad patient for STN DBS because you'll be turning the stimulator up. They'll go off, you'll turn it up. And all of a sudden they'll go on with dyskinesia. Then you'll turn down the stimulator, they'll go off. You'll turn up the stimulator, on with dyskinesia. There's no sweet spot where they're on with no dyskinesia. And that knife edge between off and on with dyskinesia, that they would be good patients for GPI DBS.
Okay. And in this initial process where you're doing the programming of the actual device, can you help me understand how are you making these adjustments? Are you using an external technology? How are you interfacing with their device?
So the device is buried under their skin and their skin is covered with their shirt. And then we will typically either put a mouse, like a wand on their shirt, or now some of the devices are just Bluetoothed. And we would be adjusting the stimulator with our computer.
Okay.
And asking them, hey, how's that? Try standing up, try walking. Let me give you just a little bit more power. Here we go. Try that. Oh, that's even better. Let's go a little further. Try that. Oh, that's better, except I think I got some tingling in my face. Oh, let me turn it down half a notch. How's that? Oh, the tingling's gone and I'm really moving well. Let's try that. And then they go away for a week and then they come back and they typically say, that's great and we're done. Or, you know what? When I got stressed or early in the morning when my meds were low, I had more of the symptoms. Can you give me more of a range so that in the morning I can have a little extra boost? Oh, sure. Let's try that. There's a little back and forth in terms of adjustments. And when we began many years ago, we were very symptom oriented. I'm going to get rid of your tremor. I hope that helps you. And now we realize that it comes in a human being. And there is an infinite variety and complexity to those human beings that have Parkinson's disease. And we really have to understand who they are. Yeah.
And speaking to the variety of human beings, you mentioned working with children earlier in the show. What would you say is the youngest age of a child who would receive DBS?
So the children that we're operating on, the 6-year-olds, they don't have Parkinson's disease. They have a different condition, dystonia. They were born with a gene that are giving them a like uncontrolled sort of rhythmical writhing of their body, so-called dystonia. That they're not Parkinsonian. And we would not operate under someone who is 6 years old because of the potential for skull growth and pulling the electrode out from where we want it in the brain. But we've operated on 7-year-olds, 9-year-olds, 10-year-olds, who happen to have this gene causing dystonia.
How do you decide between a solution like DBS and other advanced therapies like apomorphine pumps or intestinal gel therapy?
So the patients are referred to me, the neurosurgeon, from the movement disorder neurologist, and they're the gatekeeper. The movement disorder neurologist is potentially sending people to a gastroenterologist for the duodopa pump. I'd never see that patient.
Okay.
Or they're sending a patient to me for DBS. The gastroenterologist probably isn't. And the decision is probably one step further back from before they get to me, where the neurologist can then send the patient. I can tell you in British Columbia, in Canada, there is a financial constraint, and that is duodopa is very expensive, and approximately $35,000 per year for the gel itself. So
Wow.
$35,000 every year. DBS is much less than that, and it's one shot, could go for 5 years.
Okay. You spoke about other clinicians being gatekeepers. Would you say there's a limit to the knowledge of these clinicians with respect to neuromodulation, and how often does this impact patients?
So there are different levels of knowledge in the caregivers. For example, if a family doctor sent one of their Parkinson's patients to me for DBS surgery, they would probably not be a candidate, or they would be sent back and said, why don't you try adjusting these medications first? And the likelihood that patient would be a candidate for DBS would be about 10%.
Okay.
If the patient came from a general neurologist, someone who is seeing all different kinds of neurological problems, including Parkinson's disease, and they were sent for DBS, the likelihood that they would be a candidate would be about 50%. They've probably not tried all the medications or could maybe adjust the medications to get a better response. If the patient is coming from a movement disorder neurologist, then the likelihood that they're going to need DBS is like 90%. And those are the experts in the field who know all of the Parkinson's medications and have undoubtedly tried it. Otherwise, they would never send a patient to me. So when I get a referral, I usually look who's sending it. And if it's from a movement disorder neurologist, it's probably a very good referral. And if it's not, there's a high likelihood that maybe they could try some other non-surgical therapies first to see if they can improve their quality of life sufficiently to avoid surgery.
Okay, so once a patient's gotten to your office, they receive deep brain stimulation. Is this surgery reversible?
Yes. You wouldn't want it reversed because you're getting the benefit from it. But all we've done is insert platinum wires into the brain.
Okay.
You can take them out. Yeah.
Does this ever happen?
Yes.
Why would that be?
We had one patient who had an autoimmune disorder that I thought made them look very similar to a patient with MS tremor. But it really was a one-off. They didn't have a MS. And so we were trying to treat their tremor, and the surgery didn't help their tremor.
Okay.
And we took the devices out. Yeah.
So I want to think about the experience that patients have after going through deep brain stimulation. How would you say you've observed that DBS impacts a patient's sense of their self, their identity, the way that they interact in the world?
Yes, typically in a good way. It gives them back their confidence. For example, a lot of them are living at home, not leaving the house because they're worried that they're going to freeze in the mall and they'll never get back home, or sometimes they're too far from a bathroom and they can't get to the bathroom in time, and that just zaps them of their confidence. And if you can give them back their ability to predictably walk, not normally, but at their best, then they can return to those kind of activities and they improve their sense of well-being and their personal confidence.
What about advancements in technologies like around imaging or robotic surgery that may influence the outcomes of DBS?
Yeah, so advances in imaging has been super helpful. Like anything, if you can see the target, you can go to it. In the old days, with poor imaging, we were guessing where the nucleus was based on where other nuclei that we could see. Oh, it's typically a few millimeters to the left of that target that I can see. Let's go there and then hunt for it. And now with better imaging with our high field MRI, we can actually see the targets. And so I think that has been a real advancement. The ability to use a robot is neither here nor there. It's just another method of advancing the electrode. They don't do it any more accurately than you would with whatever we have. It sounds fancy. It has a cachet and potential advertisement power south of the border. Come to my hospital. I've got a robot. But the truth is, I don't think they're any more accurate than the current methods that we are using.
Are there any new potential targets within the brain that you think are particularly effective for DBS that are on the horizon?
Yeah, so we were the first in the world to treat a condition called spasmodic dysphonia. It's a task-specific vocal dystonia of the vocal folds. And we finished our first randomized control trial suggesting that there's a benefit, and we're now in our second trial to show the magnitude of that benefit. And so that's a different condition, spasmodic dysphonia.
Tell me more about your research history. What topics have you explored? How many papers or trials have you contributed to the field?
Yeah, so I'm somewhere between 1 and 200 peer-reviewed papers. It's been my world. This is what I do. And we're excited about that. We did the first in the world to do spasmodic dysphonia. We were the first to discover 2 medical conditions, not related to neuromodulation, but hemilaryngopharyngeal spasm and Vancouver syndrome are now in the medical lexicon, and people are discovering them in Japan. And that has been a personal interest to me. I actually wrote a book about it. It's called The 10th Nerve.
What inspired you to write that?
7 patients that I'd met who profoundly changed who I was. So normally as a surgeon, you keep a certain amount of distance from your patients, but occasionally you'll run into a patient who leaves an indelible mark on your soul. And I wrote a book as an homage to 7 of these patients who had changed my understanding of medicine, but also my understanding of myself.
Sounds incredibly fulfilling.
Yeah. So the book is The 10th Nerve, a brain surgeon's stories of the patients who changed him.
Beautiful. I love the title.
Thanks.
It's well chosen.
Yeah.
What about with respect to training the next generation?
Mm-hmm.
So we've got neurosurgeons, if they want to specialize in DBS, how do you impart the technical skills that are necessary? And how do you go about guiding them in terms of the ethical considerations of this procedure?
The surgeons who want to learn DBS typically do an additional fellowship.
Okay.
So and I have trained almost 30 neurosurgeons from around the world who have come to Vancouver and spent an extra year after they've finished their neurosurgical training and they're neurosurgeons in their home country. Mm-hmm. They've come to see how we do DBS or neuromodulation in Vancouver. And they come and see a team that's been doing it for 20 years and see how it's done. And so they get to learn that way.
Okay, and you're also a professor. Can you tell me about your work in academia?
Yeah, part of my job is to advance teaching and research in the field of neurosurgery. My particular interest is neuromodulation, but I'm also interested in those other 2 conditions that we're talking about, hemilaryngopharyngeal spasm and Vancouver syndrome. And part of my life is doing research and presenting it to my peers in the form of peer-reviewed publications. Mm-hmm. And going to meetings like the International Neuromodulation Society here in Vancouver to learn from other researchers around the world.
Thinking about these rather impactful relationships that you've built with patients, particularly lending to your book, and there will be a link to that in the show notes for listeners to turn to. But I'm curious whether or not you find your relationships with patients is particularly changed or impacted due to the intimate nature of changing brain function.
Well, I must say they are brave. Mm-hmm. I would have a hard time undergoing the operation. I have to hold on to the airplane seats really tightly to make sure everything goes okay. They are very brave people. And the nature of our work is such that we are seeing so many patients and we have to move through that I really don't get a lot of time in the post-operative care. But I do occasionally pass them as in the hallway when they're going down to the DBS clinic and I'm going to my office. And it's lovely to have a chat and get some positive feedback or negative feedback on how we've done. It's important to, as the surgeon, to understand the outcome from the patient's eyes because it informs you of like how you are doing. Should I be targeting that nucleus in this kind of person? Should I have moved a little bit more lateral in that with someone with that particular symptom? And it's very good to not be isolated as a surgeon to just in the OR, but to really understand the patients, both preoperatively and to get the feedback postoperatively. I think it makes you a better surgeon.
Well said. And I'm thinking about now also accessibility on a global scale. Obviously, you're working here in Canada, and accessibility is quite positive compared with certain places in the world. When we look at developing nations, what is your sort of trajectory around when you expect these procedures to be accessible on a more global scale? And have you participated in any advocacy work around expanding access?
Yeah, that's a very good question. DBS and neuromodulation is very underutilized, underserviced in countries with low economic because they can't afford it. I always thought it was almost a luxury if you're in a country and you're making your Parkinson's patients better. We have an outreach program in West Africa, in Ghana. We think Ghana will be a neurosurgical center of excellence in Accra, and they can serve as a hub for neurosurgical treatment in West Africa. And I've operated in Ghana and Liberia and trying to bring education first, and then the technology will follow. You need a champion. You need a young African neurosurgeon who is passionate about this area, and then we will support them as best as we can. And so we bring, not only do we have fellows coming from England and Germany and Australia to do DBS, we have fellows coming from Ghana to do general neurosurgery with us in Vancouver. And I'm hoping I can tweak the interest of one of those surgeons to bring functional neurosurgery back to West Africa.
Well, so the next episode of the show, we're going to interview your patient, Larry.
Yeah.
I'm curious if there's anything that you'd like to share about his case before we learn from his purview.
It's uncomfortable for me to talk about a patient. I think it probably come much better from his mouth. He's a fabulous patient. It was an honor to operate on him. He's had a great result, and I'm just thrilled and delighted, and he makes me happy. Yeah.
So on the next episode of the show, we'll interview Larry. And then thereafter, we've got an interview with both yourself and Larry coming up where we'll be able to hear from both of you together. I really look forward to those opportunities as well.
Perfect.
Wonderful. Thank you so much for being on the show today. This has been really eye-opening.
Oh, it's my pleasure, Mandi. Thanks for having me.
Take care.